So we're therapists. How can we make decisions that benefit people and help them get better? Well, in this video, what I'm going to do is describe a fundamental principle that is really useful when helping to decide how we treat people, what particular treatments we do within the session, and also the particular exercises that we give them, and making them appropriate for them. So let's start with just a simple, what is physiotherapy? What is therapy? Well, I think it's a restoration of normal movement, that's the first thing, and function. And that is particularly for an individual. So an individual has their own characteristics, alignments, skeletal aspects, genetics, that mean they are unique as an individual. What we want to do is restore normal movement, as whatever that means, as much as possible, and function. The most important thing really is getting them to be able to do the things that they want to do. So that might be just for some people to be able to function in everyday life without pain. So be able to walk down the stairs, be able to walk up the road, being able to sit for periods of time at work without pain. And for others, it might be that they're athletes and they want to build their strength and their function in a way that helps them to perform in a sporting environment and do activities and things that they enjoy doing. So whatever the unique movements and functions for that individual, we want to restore them as therapists. Now, what is movement? Well, I think normal movement is quality, first of all. Quality movement for that particular individual, so it's not stuttery or poorly controlled, poorly coordinated. It's good range of movement. We can extend range to a relatively normal range of movement, and it's not restricted in any way. And finally, we are strong in that range of movement. So movement, normal movement, I would describe it as being good quality, relatively speaking, range of movement, relatively speaking, and good strength, so that we are not going to pull things or strain things when we ask the body to do things. So if this is physiotherapy, how do we decide what we do when something bad happens? Let's make something bad happen. Injury. Injury strikes, pain strikes to our normal function and movement. What do we do? How do we make decisions as physiotherapists to make this person with this problem get better in the most efficient, and that means in terms of how quickly they get better, and also how well they get better, how complete they get better? What decisions can we make during our interaction with this individual that helps them to progress in the optimal way? And that is what I'm going to cover in a moment in this video. What we need to look at now is a very important graph that is going to be relevant in a second, but stay with me, okay, about the tensile strength of tissue. So this is a very important graph, because this graph is something that I have in my mind when I'm treating most people and restoring their function and their movement. What it is a graph that represents the tensile strength of tissue. And what we're talking about is the local tissue, which is where the injury has taken place. So if it's a strain of a muscle, it's that part of the muscle. Or if it's a strain or irritation around, say, a facet joint or ligaments, then it's those particular micro-level tissues that we're talking about, and how their strength varies as part of their recovery. This follows the natural process of inflammation, which is always worth looking up to see the stages of chemical inflammation. But what we have is a graph which represents tissue strength at one side. So we start at the lowest tissue strength down here, and then back to full tissue strength here. And this is the axis of time. So as time goes on, what we see is a tissue that gets stronger and stronger after injury. So here we have our injury. Our injury has taken place at 0 time. This was the point of injury. And so our tensile strength is very low. It's right down at the bottom. And so in that early stages, the tensile strength of the tissue, that localized tissue that's been disrupted, is very low, and it's got a low capacity for loading. And as we go on, actually that accelerates and gets steeper and steeper, because effectively the more we can do, the more we can strengthen. And so the initial stages are very, very slow, but then we actually build up our momentum and can get going until we get to our full recovery level. The reason why this is relevant is because we have to consider when we're treating something where on the graph their particular problem is. So if it's just happened or we have a repetitive strain that hasn't been removed yet, then basically we're going to be right down in this area through here. And if we try to load it too much, then what's going to happen? We're going to see something else happen. Instead of this nice curve that we've got, we're going to see initially an improvement, and then they come and see us and we decide that we're going to really stretch an area that is tight and restricted, or we're going to put grade 4 manipulations into joints which are irritated. And what they get after they see us is bang, back down. So they get more pain and their tensile strength actually gets worse, and then they have to recover from that, and then the process starts again until they get going. And that is down to us. We have overloaded a tissue, which means that then we've caused too much disruption and therefore we've set them back. It's not an exact science, and we will get it wrong at times. We will provide a force in terms of treatment or exercise which is perhaps slightly too much for the tissues, but that's where we get our feedback loop of test, retest, our intervention, or seeing how they get on with some exercises and then adjusting accordingly. But of course, optimally, if we haven't overloaded it, then effectively what we can do is through our loading and through our tissue, we can accelerate the time that it takes to get better. So actually, instead of, if it was just a process of time, they might get over here and they might not get to full recovery. But even in the process of time, if they do, they get up there, it's a longer period of time. With our interventions that we can provide as physiotherapists, then basically we're looking to accelerate that curve to get to this level. Our interventions need to be appropriate to whatever level this particular graph is at. How do we tell that? Well, it's because pain levels, they're one thing. Lots and lots of pain levels. I know there is nuances with this, and the fact that you can have chronic pain in the absence of damage, but we've got to use pain as an indication about our interventions, because even if that is just an over sensitivity to pain and not a true tissue damage, we still, if we go in hard with it, may well just cause more pain, which in turn is going to spasm things up and reduce our process of getting back to full function. So even if pain is the factor, we still need to consider our interventions as if they're in more pain, we'll do lighter interventions, and if they're in less pain, we will be able to do more extensive interventions or load it more in terms of exercises. Same thing goes for stiffness. If an area is very, very stiff, if we go in there hell for leather and try to really stretch it, there's a potential that we could disrupt some tissues and make it uncomfortable, overstretch it for the state that it's in. But if we start with smaller range of movement, limited range exercises or interventions, then we're going to start to just gradually loosen up that stiff tissue. So the same applies for stiffness as well. How they respond to what we are doing is how we decide kind of where on the graph they are with this, or how much function they are losing or they've lost will also be a factor of how we decide where they are on this. But it's really, this is what we're thinking all the time with our patients, is where are they and how much load can I apply to this tissue? Because we know that loading will provide, appropriate loading will provide a positive response, positive adaptation, greater strength and restoration. So we get better quicker. So how do we grade our own interventions? Let's cover that now. Okay, so here is my recipe for grading your treatment so that you can appropriately load according to our tensile strength graph. So in terms of treatment grades, I tend to use the principle of maintenance mobilizations, but it also applies to exercise as well. So on our highest level of pain, when we have an injury that's more acute, we're going to use grade 1. Grade 1 interventions really are that we have small oscillations. So if we're doing mobilizations of small joints or muscle tissue, then we're going to use small, low duration, small range of movement interventions in this particular instance to mobilize the tissue. We're also going to have exercises, obviously. We're going to have a limited number of exercises because the person's in quite a lot of pain, and we're going to have relatively low number of reps because we don't want to flare up that tissue. We want to give it enough recovery time. Obviously, load is very, very low or not at all. It could be unloaded completely in this range. But when we've got high levels of pain for a particular problem, then we're going to think about starting off, and then as we progress from grade 1, we can then move to grade 2. Now the pain is reducing all the way down this side. We're seeing as we go on with our grades and increase our intervention, the pain is getting less, and we're moving to more towards a stiffness as the main symptom rather than pain as the main symptom. Grade 2s. Grade 2s, we're getting out of that acute painful phase. The patient is tolerant of a bit more pressure. And of course, this could be that straight off the bat, somebody isn't this bad in terms of pain. And we can start off on this, or we can start off on this, depending on where they are on their recovery cycle, on that tensile strength graph. We don't always have to start at the beginning because we don't always see the person at the beginning. So in grade 2, we're going to have moderate oscillations in terms of our mobilizations. We're going to take mid-range range of movement, and we're going to use perhaps gravity or body weight, so some light added resistance to start to introduce in this area here. As our tensile strength of tissue starts to improve and we get less pain, we can then progress onto grade 3s. Now grade 3s is the real meat of when we see some real progress. Remember, the curve starts to go exponential as we go upwards towards grade 3. We can do more. They can do more. They can do more reps, more exercises, more activities, and this is all going to help, provided we don't overload it, to progress them more quickly, to get that positive adaptation to the tissues. In grade 3s, we're going to do full range of movement. That might be full range of movement stretches while we're treating them, or it might be full range of movement exercises. We're going to use firm pressure on our mobilizations and soft tissue work. The pain is much, much less, and so they're tolerant of a lot more. And if we can mobilize them a little bit more, then chances are we're going to improve their range, we're going to improve the situation in it and improve those tissues. So we might use stronger resistance. We might start with a lighter band, but then progress to stronger bands over the course of this grading of the problem. And this could be over a number of weeks that they stay in this grade 3 type of area. It's not necessarily in weeks at all. The period of time can vary from a few days, or it could even be, as I say, getting into weeks and weeks of being in grade 3 area. But we're adding resistance, we're adding perhaps light weights into it. Load tolerance is increasing, therefore we're going to give appropriate loading, and that is more in this phase. And of course, pain is getting less and less and less, remember. And so grade 4 is when we're really at the end of this with a patient. They're at their end stage, they're nearly better, and we can add some quite challenging exercises with some heavy loads. They're not going to suffer because the pain is gone essentially, and we are appropriately loading. We're increasing that load because they're tolerant of it. On our curve, we're right at the top of that curve, and we are essentially nearly back to normal. We can do end of range stretching, and our pressure and mobs and soft tissue work is all as pretty firm, pretty strong, to get us to that end of range, to get rid of any stiffness that is left over. And that is how we grade our treatment in line with our tensile strength of tissue graph. And that's how I decide in my mind how I'm going to intervene with somebody, how I'm going to treat somebody on any given day for any given problem. That's how I decide. I'm going to evaluate where they're at in terms of their acute tensile strength, and then I'm going to decide what are the appropriate grades for that particular problem. And if I do that, and I've done that for many, many years, I have found that I don't overload people as much, and that my treatment is appropriate. It actually helps them to progress onto the next level, and that's the secret sauce. Okay, so let's tie things together between where we are on this graph and our treatment interventions. So if we draw our curve again, and so the tensile strength of tissue over time and with our interventions gradually increases till we get back to full recovery. Now, in the early stages, we might only use our grade 1s, our very small oscillations, very small range of movement, and in terms of exercises, it could be very or no load. It could be passive range of movement, it could be active assisted range of movement. It is lesser load because down here the tensile strength is less, therefore we need it to get going. But we know the benefits of getting things moving, even if they're in passive range of movement, for example, and under no load. They will affect the tissues. So down here we might use our grade 1 type of interventions. Going forward, as the strength improves and the capacity of those tissues improves, then we might go to our kind of grade 2 sort of area. So grade 2 interventions might be that we are slightly increasing our stretch when we're doing stretches. We might increase the pressure to grade 2 mobilizations if we're mobilizing a particular area. And in terms of load, we might be starting to use active range of movement against gravity, for example. Free range of movement. It's a step up from our early interventions, but the tissue and the person's pain and stiffness is at a level which it is ready for, and we're not going to have that incidence where we overload it and excessively then lose our tissue strength back there and have to recover it. Instead, appropriate loading and appropriate interventions means we're going to progress more quickly into these kind of ranges. So obviously it makes sense that the next level we might do our grade 3s, and with grade 3s in terms of mobilizations for say manual mobilization of joints, then they're more extensive into range of movement stretches. We're going into a deeper range of movement because the tissue can tolerate it. So the less pain and more in terms of resistance is really the symptom, and stiffness. So we've got license in this area to go into greater range of movement without worrying about causing extra stress to it and more irritation and then going off again. Let's get rid of our little curve that causes us doing the wrong treatment. And then of course, finally, as that person has progressed, they are now doing, say, body weight loading in terms of legs, in terms of arms, they maybe are using light resistance bands. They are taking range of, they're maybe doing bridges against gravity. These kind of interventions are more loaded than just gravity. They might be using body weight, for example, but they're not hugely loaded until we get to our grade 4 interventions. We're kind of like 80-90% better at this stage. And so many people will stop seeing the patient at this point because most of their symptoms in terms of their pain is resolved once you get to this kind of level. However, they're not fully better because they're not fully rehabbed. We want a restoration of full strength and function and quality. And so how we get that is we start to load it even more. We might be using stronger bands. We might be taking, using actual weights. We might be doing plyometrics. These kind of interventions are these last little bits, stretching fully into end of range to really get rid of any last bit of stiffness that we've got there. And we will maximize the normal movement and quality for this particular individual. All the time, we should be thinking about how the graph corresponds with the symptoms, corresponds with our interventions, matching them up as much as possible, which reduces the risk of us doing a treatment which makes them worse, or giving them exercises which makes them worse and overloads it and causes it to be a problem. This is the magic sauce of every single patient that you see. You have to consider what stage of recovery they're at and what your intervention is designed to do. So let's take a couple of examples about how we would fit this in to real life. Simple hamstring injury to begin with, a muscular injury. So we have an injury, we're playing sport, an injury takes place, and it's acute, and you see them within the first few days after the injury. then basically we're going to be down. Let's assume that it's a nasty injury like a grade 2+ or a grade 3, and they're going to have low tensile strength in that particular tissue. They're not going to be able to do an awful lot. And so initially we might only do unloaded range of movement exercises, obviously your typical ice, rest, and protection phase. We are unloading the structures, allowing the early stages of healing to take place. Now that could be over a number of days that actually happens. But when they come to see us the next time, what we're going to look at is obviously, has the tensile strength improved? Now, muscles heal fantastically well, so we'd expect, certainly over 5 days or so, for the strength to have improved a little bit. And then we can start to gently take the range. If we start to, we won't necessarily fully stretch it, but we'll take it into a slightly more end of range. We'll be much more willing to do that than we would when the injury has just happened. So we intervene by taking it into a slightly further range, and we might be at that stage that we can start to do some gravity related range of movement exercises in the range that they've got, which will be limited, of say knee flexion when it comes to a hamstring injury. And so over that period of time, we might do our soft tissue work as well, gentle soft tissue work. If we went in hell for leather into that hamstring, really got our elbow into it and did lots and lots of soft tissue work into that hamstring, what's the chances that it's going to be really sore and we've disrupted tissue that is in the process of healing and it's too much for it, and the person would have been set back every chance in terms of their tensile strength. So we don't do that. We're going to do gentle work, maybe around the area, not specifically on the area, to gently stretch, release tissues, but encourage that healing process for that tensile strength. The next time we see them, it's improved further because our interventions and our exercises have been appropriate. It's stronger. They can walk maybe a little bit more now, whereas before they were hobbling around. At this point, we can start to introduce more resisted work, so isometric bridge lifts, for example, or using a TheraBand against resistance in a concentric way to bend up the knee and to work the hamstring lightly in that way. It might start off with a very light band and then through this particular zone increase the strength of the band as well. We might start to incorporate some things like squats, so just some simple standing bodyweight squats that are going to just take the tissue into a further range of movement and further strength, further load. And then this might last some time. And then when they can do a little bit more, they can run, they can maybe not sprints, but they can certainly, they're getting through their exercises from grade 3 without any great difficulty. It's fairly straightforward for them. We're going to progress them into grade 4, where we will start to do a little bit more eccentric work, higher loading, maybe some lunges, starting to run a bit faster. And these are the interventions, of course, sport specific stuff if it's a sporting individual, where we actually are going to start to do some sprints with control and get them back to game readiness. So that's an example of a hamstring. What if we were thinking about acute low back pain? So somebody comes in with acute low back pain and they are in a lot of pain. For example, they bent over to lift something, the back has gone into spasm and they can barely move in any direction. Now with that, obviously initially we're going to do some gentle movements. We're going to maybe just take the knees rocking from side to side in crook lying, an unloaded position, not full range, not taking the knees right the way over, but just in an inner range where we start to loosen up some of the spasm. That's the goal really, is to reduce the spasm in this area. And then very simply, soft tissue work, lightly, in spasmodic tissue, gentle mobilizations perhaps to joints around the lower back, with the goal of trying to, the first thing is we want to increase range of movement. So as far as the back's concerned, our key determinant through this phase here, through grade 1 and grade 2, is that we want to increase their range of movement. We want to restore their range of movement. And with that then, we can use that range of movement, say for example standing and ability to bend forwards or whatever the restricted movement is. We can then use that range of movement as a measure to see what stage we're at through the process. Once they've restored most of their range of movement in a particular direction. We can then start to do more extensive mobilizations, stretching a little bit further, say side lying, little rotations to mobilize the back. We can stretch off glutes, we can do trigger point release, we can do more things that are going to take it into further range. And our goal from that perspective is to get rid of stiffness. So we've stored range of movement, then we'll have stiffness at the end of range. So get rid of that stiffness at end of range. And of course we can incorporate a little bit of strengthening into the lower back through various things like bridges or bird dogs, etc. So in this phase, we want kind of strength to occur through these kind of grades through here. And then on we go. But the point is that whatever we're considering, whatever patient we're considering, we're always taking into account what their symptoms are in relation to the likelihood of the tissues. Now, obviously, this is not talking about chronic pain patients or complex patients who these rules maybe don't apply to. This is not hard and fast rules, it's principles, and we have to be light on our feet in terms of deciding and being creative within it. But it's a general principle that if we think about where that patient is in terms of this graph, our interventions will be appropriate. If our interventions are appropriate, we're less likely to overload them and cause them to feel worse, which is never a good thing for private physiotherapy. And it means that we're going to spread those interventions over a number of sessions, which of course is good for business as well, because we're taking them by the hand, step by step, guiding through this process of getting better, rather than just getting here, maybe giving them exercises for this particular point of their recovery and expecting the rest to take care of itself. Sometimes it will, sometimes it won't. But that's what I would describe, say, NHS treatment to be like a lot of the time, is it's a one and done, off you go kind of scenario. We're a bit more precise. We are taking that person by the hand and guiding through the whole process. And it's very fulfilling. They get better. They get feeling like they have fully recovered and a confidence in going forward in the future. So I hope that helps and you can understand why this graph is so important for every single patient that I see.